Another patient presented with a vitreous prolapse and retinal detachment. And another patient who came with, presented with aphakia, we were suspecting a posterior dislocation, and on USG-B scan, the crystalline lens was found in the vitreous. Preoperative management, all patients were treated with topical steroids and anti-glaucoma drops, and pupilloplasty was done following subsidence of acute inflammation. A patient with Berlin's edema was preoperatively treated with nepafenac and prednisolone, which resolved 2 months later. Another patient underwent SICS with PCOL first, followed by SFT 1 month later. 2 of the cases could not be operated, one with the retinal detachment and the Purshaw's retinopathy. The surgical technique, there's a proximal and a distal clear corneal incision. A straight round-bodied needle with 9-0 or 10-0 Prolene suture is passed through the proximal flap of the iris, which is held with the help of micro forceps, and the 26 gauge needle using a railroad technique holds the round body needle and pulls it through the distal distal incision. The Sinskey hook was used to create a loop from the distal end of the distal part of the suture, and the proximal end of the suture was cut, and the end was passed 4 times through the loop, and the knot was slided into the anterior chamber and gently pulled, and both the ends were gently pulled, and the ends were cut. Post-operative findings, all patients showed improvement in BCVA except one patient who showed signs of persistent cystoid macular edema post-op, and another patient showed extremely high IOP because of severe iritis, and further that patient developed open-angle glaucoma, secondary open-angle glaucoma, which was managed conservatively with eye drop prednisolone hourly and eye drop brimonidine and timolol. So, coming to the take-home message, the advantages of single pass flow through pupilloplasty include shorter duration of surgery, minimal number of times the microhook is passed through the AC, which leads to lower risk of infection, and minimized corneal endothelial cell loss and lower chances of knot slippage. Clinical implications of pupilloplasty are improved visual function, enhanced light sensitivity, corrected anisocoria, and enhanced cosmetic outcome, and treatment of a traumatic pupil. That's all. Thank you.
Very good, madam. Did you consider, because most important aspect in the trauma is the comorbidity?
Yes,
because
sir.
there are damage to multiple structures.
Yes, sir.
So when you have retinal detachment, when you have other conditions,
yes,
those will impact on visual outcome, right?
Yes,
so that variable we have not considered in the study.
Yes, sir. Sir, actually we only took those cases who present with only ocular trauma, no other...
Yeah, but ocular trauma can impact the lens, can impact the zonule, can impact the
yes,
angle. So all these
yes,
pathologies also will impact the visual outcome.
Yes, sir. Yes, sir.
So those factors are not considered as a variable in the study. That's what is my question.
Yes.
Or did you have any mechanism to eliminate that confounding factor?
Yes, sir. There was one patient who presented with anterior subluxation of the lens, and that patient underwent pupilloplasty along with PPV and IOL implantation.
Right.
So that was a combined surgery done for that particular
obviously, but that patient and simple patient with traumatic cataract cannot have the same outcome.
Yes.
So when we are comparing that.
Yes,
right.
sir.
Thank you.
Thank you, sir.
Okay, thank you.
Thank you, sir.
The next, Dr. Sakshi. She is present, not? Dr. Deepak? Not present. Dr. Bhumi Chandarana? Can mark the absence. Again, Dr. Sakshi, so she is not there. Dr. Midhu Matthews?
Dr. Midhu Matthews? Saujanya? Dr. Saujanya, come, please come.
Good morning everyone. I'll be presenting a study on factors affecting visual outcome after the surgical repair of limbal corneal laceration. Open globe injury is a significant cause of permanent visual impairment and blindness worldwide. Around 1.6 million go blind from ocular injuries. Corneal laceration and corneal perforation are common ocular traumas with potential devastating sequelae, including corneal scarring, astigmatism, and endophthalmitis. Factors likely to predict the outcome after open globe injury includes mechanism or type of injury, preoperative visual acuity, time lag between the injury and surgery, relative afferent pupillary defect, size and location of the wound. The other factors predicting outcome are associated retinal detachment, uvea or retinal tissue prolapse, vitreous hemorrhage, lens damage, and hyphema, and number of operative procedures done. Corneal scars after perforating corneal injuries cause significant visual reduction due to the direct obscuration of rays by the opacity and irregular corneal astigmatism that results due to the scar. In developing countries with the paucity of donut material, corneal contact lenses are considered as the first choice of optical rehabilitation in the eyes with corneal scar following the repaired corneal perforation. All lacerations require urgent repair to reduce the risk of infection, decrease tissue necrosis, and alleviate patient discomfort. Typical recommendation for a repair is within 24 hours. The goal of any repair is watertight closure, restoration of normal anatomy, and limiting the amount of postoperative corneal scarring and astigmatism. Counseling and prognostication is an internal part of managing ocular trauma. As aim of the study is to determine the visual outcome and factors affecting the visual outcome after surgical repair of limbal corneal laceration at the tertiary care in South India. It is a retrospective study conducted at the Tertiary Eye Care Center in Andhra Pradesh, state of South India, approved by Institutional Ethics Committee and adhered to the tenets of Declaration of Helsinki. All the cases with the limbal corneal laceration are included in the study. Over a period of 10 years, studied over a period of 10 years from February 16, 2011 to February 15, 2021. And the minimum follow-up for 3 years are included in the study. And cases operated elsewhere before presentation and corneal lacerations without limbal involvement were excluded from the study. Factors studied are demographic data, place and mode of injury, visual acuity, anterior and posterior segment examination was done, and B scan and CT to rule out foreign body. The factors studied in this study are age, gender, place of injury, object causing the injury, size of laceration, safety precautions were taken or not, preoperative and postoperative best corrected visual acuity, presence of or absence of hyphema, pupil size and other irregularities such as iris prolapse, iododialysis, sphincter tears, cataract and subluxation or dislocation of the lenses, scleral involvement, vitreous prolapse, duration between the trauma and surgery. Need for secondary surgery in postoperative period. The visual acuity is categorized according to WHO visual impairment categories. A favorable anatomical outcome was defined as preservation of globe and absence of hypotony, attached retina, and absence of active inflammation at the last visit. Postoperative management included ciprofloxacin 0.3% eye drops, prednisolone 1%, tapering doses for 6 weeks, suture removal for the healing, and refraction and contact lens trial whenever needed. Statistical analysis was done with stat of A4 14.2 and bivariate and multivariate analysis was performed to evaluate the factors associated with visual outcomes. In the regression model, independent variables such as preoperative best corrected visual acuity, mode of injury, size of wound, scleral involvement, hyphema, iris prolapse, lens status, duration of surgery, intracameral antibiotic use, and type of second surgery were included. P-value less than 0.05 was considered statistically significant. Our results showed the number of patients included in the study is 20. The average age was 42.6 plus or minus 22.4 years. 8 patients were from urban areas and 12 from rural background. Average age between the injury and the surgery was 48 hours. This is the plot showing the comparison between the initial and final visual acuity. The preoperative factors studied are mode of injury by stick in 4 cases and iron rod in 2 cases, size of wound 4, average size of wound is 4.9 plus or minus 2.4 mm. Hypema seen in 12 cases and iris prolapse in 15 cases, traumatic cataract in 4 cases. Duration between the trauma and surgery is 44 hours.
Conclude, please.
Yeah, sure. The bivariate analysis showed the preoperative visual acuity, mode of injury and size were statistically significant. Rest are not statistically significant. Multivariate analysis showed preoperative visual acuity and mode of injury are statistically significant. Males are more commonly involved, about 75%, and visual outcome is age is not in our study. Average age is not influencing the visual outcome, and initial visual acuity is the most important prognosticating factor in penetrating injury. In our study also, presenting visual acuity was a determining factor. Hyphema is a predictor of visual acuity studied by Barr et al. In our study, we did not find any significance. Time lag between the injury and the surgery was adversely affected the visual outcome, but though not statistically significant. Limitations of study are retrospective study. Larger sample size is required to improve statistical power. Additional studying astigmatism in the follow-up evaluations might have provided additional insights. Conclusion: preoperative visual acuity, mode of injury and size of the wound affects the visual outcome after the surgical repair of limbal laceration. Preoperative visual acuity and mode of injury was statistically significant in even in the multivariate analysis. While the time lag between the injury and surgery may negatively impact final visual outcome, but this effect was not statistically significant in our study. Thank you. This was our study.
Did you find any post-operative infections after?
No, sir. No.
When you say limbus, did you consider all zone 1 or 2?
Zone 2. Up to limbus is zone 1 and...
No. Your all cases, if it is limbus, maybe it's zone 1 or zone 2. Both can be
Both
there,
can
right?
be there.
So, that any distinction done between 2?
In our study, no, sir.
So, your suture material, your
10-0 nylon. 10-0 nylons.
If it is clearer, then you may use the Vicryl.
Vicryl, yes.
Right, thank you.
Thank you.
Raju Kumar. You can start.
How to connect? Here I am presenting management of delayed sequelae of ocular chemical injury at tertiary care center. I have no financial interest on the subject of matter. Ocular chemical injury is an absolute emergency which can threaten sight and life. Two broad categories are acid and alkali chemical agents. Alkali causes more damage by the saponification of deeper penetration and as a consequences, while the acid cause rapid coagulation of the tissue which impedes the penetration and limit its damage. Majority of the cases report to our tertiary care center after the mean duration of 48 to 72 hours. Even after the meticulous management of the acute phase, most of them landed into the sequelae. Coming to my first case, a 5-year-old male child presented to our center after 72 hours of the thermochemical injury with hemifacial burn and tense periorbital edema. Child was unable to open eyes, so we could not examine the ocular structures. Ultrasound B scan was done, revealed the normal posterior segment. Conjunctival swab was sent for the culture and sensitivity. Child was managed conservatively. with IV fluid and oral antibiotics, and burn wound care was given after the consultation from the pediatrics and dermat opinion. Day 2 of the hospitalization, child was still very uncooperative and photophobic. After all workup of the GA, UA was planned. Lead was on examination. Lead was edematous. Eyelashes were charred. Few carbon particles over the lid margin. Conjunctival congestion with chemosis, and limbal vessels were blanched. Cornea was hazy with epithelial defect noted on after fluorescein staining, but no conjunctival stain. Retained carbon particles in the cornices were thoroughly washed with BSS, and BCL was applied. Patient was further medically managed with the topical broad-spectrum antibiotics, preservative-free lubricants, topical steroids, cycloplegic, and IOP-lowering agent along with the oral ascorbate and doxycycline. Day 7 of the hospitalization, after 1 week of the aggressive management, the child was unable to open eyes, though photophobic. Conjunctival edema reduced, limbal vascularization achieved. 2 to 3 mm of the epithelial defect is still present, so the frequency reduce and converted to the surface steroid loteprednol, rest advised previously. Patient was discharged with the instruction to follow up weekly and SOS, but unfortunately didn't follow for last 6 months and reported with a complaint of reduced vision. On examination, symblephron was noted arising from the lateral aspect of the lid and bulbar conjunctiva, shortening of the palpebral aperture. Cornea was hazy and internal structure hardly visible from the nasal cornea. AC was though formed, conjunctiva quiet, and digital tension seems to be normal, and visual acuity dropped to the perception of light only. Patient was planned for the left eye symblephron release with conjunctival autograft and with AMG coverage, with an ASOC2 was performed prior to the surgery. Symblephron tissue was excised over the cornea, and corneal scapular polishing was done from the remnant tissue. Bare sclera defect was measured and taken from the contralateral healthy eye. A double-layered amniotic membrane over the fibrin glue was secured with the nylon tanno suture. Coming to post-operative day, eye was found to be, though there was significant corneal edema with lot of watering, graft was placed on an healthy. Standard post-operative care was given with a satisfactory condition. After 2 weeks, there was no improvement. After 2 weeks, there had a dramatic visual acuity of 6/12. Coming to the second case, a 9-year-old boy presented to the center with a progressive drooping of the right upper lid. Trauma was due to the accidental burst of the lime tuna packet after 3 months back. Yes. On retracting the upper lid, symblephron noted encroaching the 2 mm of the peripheral cornea, causing the mechanical ptosis. Surgical correction was done like the previous case with the symblephron release, conjunctival limbal autograft, and AMG coverage. Post-operative examination, so full and free extraocular movement with a visual corrective, best-corrected visual acuity of 6/6 and discharged with a routine medical therapy. 4 weeks after the surgery, child gained a good cosmesis and vision, currently under the routine follow-up. Discussing my case, delayed sequelae of the chemical injury, if not managed adequately at the acute phase, lead to the conjunctival adhesion and persistent epithelial defect, limbal stem cell deficiency and scarring, decompensation and thinning of the cornea, even leading to melting and secondary glaucoma. In our 2 cases, symblephron acts as a delayed sequelae which was managed with the standard medical and surgical protocol. It shows the chemical injury is an entity which needs a multidisciplinary approach with a good restoration of the ocular and anatomical function. Concluding my case, symblephron is the common delayed sequelae of the chemical injury. Educating patient and attendant about the risk factor and the need of the close follow-up is very important in managing the case. AMG plays a vital role in the management of such cases. These are my references. Thank you.
You didn't talk about slit.
Yes, sir.
You didn't talk about slit.
Yes, sir.
You didn't mention anything, treatment.
So we didn't perform slit in this patient.
When we will do slit?
So slit generally performed when there is a limbal stem cell deficiency.
When you will do perform?
Corneal complete opacification with vascularization of.
How many clock hours?
More than 6.
Okay. Next is Rajnil Bhattacharji.
Good morning, judges. I am Dr. Rajneel Bhattacharjee, Registrar, Shilchar Medical College and Hospital. It's not proceeding. Next page. Thank you. Okay. Blunt trauma forms a major part of ocular trauma. Blunt trauma forms a major part of ocular trauma. It can occur either due to direct blow to the eye by fist, ball, or blunt instruments like sticks and stones. It can also occur following road traffic accidents or in industries. Many ocular injuries can be prevented by using appropriate protective gear like helmets or goggles and seeking necessary medical care. The extent of ocular damage depends on the severity of trauma and can range from obvious ocular damage to obscure long-term effects. The aim of the study was to assess the different effects on eye and vision due to blunt trauma to the eye. It was a prospective hospital-based study. 100 patients with blunt trauma injuries of all ages and sex presenting to ophthalmology, OPD or emergency department over a duration of 6 months were included. The inclusion criteria were any blunt trauma injury patients of any age or sex, and the exclusions were like trauma with sharp objects like knife, pen, needles, or chemical injuries, or if any patient has pre-existing ocular diseases affecting visual function. A detailed history, including demographic details and injury factors, were taken. Initial visual acuity on Snellen's chart, external examination, slit lamp examination, tonometry, dilated fundoscopy, gonioscopy was done. Further investigations like X-ray orbit, CT scan, USGB scan were done in relevant cases. Informed consent were taken from all the patients. If we see age-wise distribution of patients, the most common age affected was 21 to 30 years, where around 28% of injuries occurred. If we go for the sex-wise distribution, we can see there is male preponderance with 69%, and if we divide the cases depending on the source of injury, so the most common cause of injury was RTA, that is in 63% of cases, followed by the physical assault, which constitute the majority of the blunt trauma cases. Now, if we divide on the visual deficit at the time of presentation, so we can see that only 55% of patients had no visual deficit, and in 23% of patients there was only uniocular deficit. Now, distribution of cases based on orbital injury, the most common presentation was with ecchymosis in around 71% of cases, and followed by 58% cases which had lid enema. With depending on the anterior segment injury, the most common 42% had only conjunctival congestion and 27% had subconjunctival hemorrhage, with few cases having abrasion or hyphema, only 2%, 4%. And on clinical finding on the posterior segment, only 2% of patients had retinal detachment, 1%, only one patient had Berlin's edema, and 2 patients had vitreous hemorrhage. Similar findings were done in other studies like Jain BS, Soni SR, RN Kushwaha, Rashmi Rastogi, and Doti GH. So, to conclude, from this study and the other studies, we can infer that young adults, that is the age group where it is more prone to blunt trauma to the eye, and the majority of injury are associated with lid and anterior segment, with majority having no visual deficit, but the most common cause of blunt trauma injury was the road traffic accident, followed by physical assault. Thank you.
So, did you perform some investigative procedures like OCT for
yes,
this patient? For
all the
patients?
required investigations were done. For management was different. This was just on the presentation and to find out the cause, where we can see the more common of blunt trauma, or if we can try to reduce.
According to your study, all 7 rings are not affected. Almost in 1 or 2 cases only,
yes,
one
sir.
ring is affected.
Yes.
Remaining all cases, nothing has happened.
Nothing happened.
Great.
So blunt trauma is very common, but
First of all,
injuries
blunt
were
trauma
very.
is not according to current traumatology. There is no word like blunt trauma. It is a closed globe contusion. Right?
Yes. Thank you. Thank you, sir.
Dr. Bhavik Panchal.
So good morning all the judges and good morning to the audience here. Can I start? Okay. Is it audible now?
Yeah.
Yes. Please let me know when to start. Okay. So I'll be presenting about anterior segment OCT to diagnose occult scleral tear. It's a novel non-invasive technique. So what is common to all these three pictures what we see here? Okay. All these three cases have a suspected occult scleral tear or a suspected intraocular foreign body. So what to do next in such cases? Can we predict which cases will need an intervention and which won't? So to identify and make things easier, rather than going for a surgery directly, we went ahead with an anterior segment OCT in such cases. So I'll take you around through three cases. This is case number 1. A 65-year-old male gives history of diminution of vision which is noticed 1 week prior, and he was alleged history that he did not suspect there was any trauma to him. However, if you see here, you have an area of blotchy subconscious hemorrhage, which suggests that it is already in the resolving phase. You have a mid-dilated pupil with posterior synechia, okay, and the deep AC. You do not have the slit view here. Or the B scan was suggestive of retinal detachment. Again, our suspicion of trauma been much higher here. So if we examine this area closely, this is a small nevus here, but this area somewhere we had a doubt, a suspicion that okay, there might be a small opening. So we went ahead with the UBM and it showed that, sorry for the artifacts here, it showed a defect with suspected vitreous incarceration. So we went ahead with the anterior segment OCT for the same patient through that area, and to our surprise we found a full thickness scleral defect here with the vitreous going into the wound, as we can see here in different sections as well. So this was the first case where we tried this intervention. Coming to case number 2, we see here again a patient with post open globe injury. However, only we had a conjunctival laceration. This was a girl who was 8 years of age, and before taking up for surgery, we thought let us go ahead with our intervention with the anterior segment OCT. So we see the conjunctival defect here, and we also noted a scleral defect underneath that. Okay, and there was a foreign body as well, which was picked up on the B scan. Case number 3, this is a post-operative repaired corneal tear, again sent here because the patient had constant irritation, redness and congestion. To our surprise, in the ASOCT we found a foreign body which was embedded under the sclera. Okay, so there were total 6 cases where there was good correlation between the ASOCT, UBM and the intraoperative findings. Intraoperatively, the surgeon could correlate with the ASOCT findings, and it helped the surgeon to locate the tear and repair it properly, or even remove the foreign body as per the location. To conclude, ASOCT is an important non-invasive diagnostic modality to diagnose especially occult scleral tears. It gives a confirmatory diagnosis of occult scleral tear which could have been easily missed, and it increases basically the positive predictive value in diagnosing such tears. Obviously, it cannot go beyond a certain level, beyond say the equator or near the spiral of Tillot to diagnose it. So surgical exploration though remains the confirmatory diagnosis, ASOCT aids in terms of identifying the tear and giving the location to the surgeon, and rate of surgical exploration can be reduced significantly with such maneuver. Thank you so much.
Very good, sir. Nice presentation. Sir, UBM or OCT?
Very good
which one is
information.
Better, UBM or OCT, which one is better? Both are equal.
So we correlated that. Say the more crisp images you get with the ASOCT, especially if it's in the anterior segment. Yes, UBM again may not be available in all the centers, whereas OCT now comes with the package of ASOCT, which includes. So we do not find, to be honest, any difference between the two.
But if we suspect some breach in the ocular wall, UBM will require immersion aspect. So,
sorry, UBM will require?
for UBM you need a fluid,
Yes.
right? So that is a very serious issue. That is the reason UBM was not used in trauma cases.
Correct.
But the entry segment OCT is non-contact system.
Non-contact
So that will be very helpful, and the presentation was very good. Fine, thank you.
Thank you so much.
Okay, doctor.
Thank you so much. Thank you all.
Doctor Ashish Goyal.
Kashish Goel. Shakti, Dr. Deepak.
Anybody who wants to present, who misses the help?
Any absentee were present? Okay. Thank you all. Can we have one group photograph? You want to present? But you don't need to, because there was a tie and I had another paper which I already withdrawn because I wanted to be here. I don't think you need to present now. Yeah, you don't require to present now because that case is over. Right? I was the second one. So I'm not presenting, so you are given for yesterday. So today they will come. Can all come for group photograph?